All right, thank you everyone. Thank you for being patient in a long session. So if Leslie took you up 10,000 feet, I'll try to take you up 20,000. So get ready. So while this meeting and many discussions of genomic medicine fix their sights on the future, I actually want to spend my few minutes with you on what matters most for the vast majority of citizens and patients, and that is the now of genomic medicine. I want to actually begin, though, by recognizing, which I don't think we have recognized yet in this meeting, that it is important to aspire to offer hope for a better future, especially in these times of historic inequality, where a healthy, worthwhile life is out of reach for too many. However, for what many of you do every day, and for many patients, what matters is not 5, 10, or 25 years from now, but today, tomorrow, next week, or as Kate Bowler, who is a stage 4 colon cancer patient, a recipient of immunotherapy, and author of this best-selling book, Everything Happens for a Reason, and Other Lies I Have Loved, and I love this title. What matters is the next 2 months. In the now, today, immunotherapies are extending life in 2-month intervals for some, like Kate Bowler. For others, like my uncle, they are extending life for 2 months before drastically and quickly ending them. As we've been hearing about at this meeting, the new immunotherapy drugs work by releasing the immune system and thus can lead to fatal immune-related adverse events. These drugs also cost something we haven't talked about too much yet, hundreds of thousands of dollars a year. This is an article in Genome that you can read by my colleague Misha Angrist about this. So these new therapies are inching near $1 million a year and putting pressure on already stressed healthcare systems and placing them out of the reach for the increasing number of people who either do not have health insurance or who pay high copays. But for the vast majority of people today, though, and what we've been talking about in this session, the now of genomic medicine is not receiving these novel treatments, it's receiving novel testing. For these individuals, today's genomic medicine is filled with many questions and uncertainty. Many get their genome sequenced and wonder what it means. Even for diseases like breast cancer, in which genetic variants are clearly linked to pathology, there are still thousands of variants of unknown significance, and most may not be pathological, but nonetheless create problems, despite what Leslie said, anxiety, uncertainty, the unnecessary removal of breasts, and I will I also cite this Oregon case. I think this had to do with a VUS interpretation. And if there were more genetic counselors in Oregon, maybe this would have been addressed. Many, even the majority of patients, must navigate this testing without the help of a genetic counselor. I think you might have, someone cited this report already. This report in JAMA of 773 women considered to be at high risk for breast cancer, 81% reported wanting to see a counselor and only 40% reported speaking to one. And this is something we might want to talk about in the panel later on, in our discussion later on. In UCSF's WISDOM study, a study that seeks to enroll 100,000 women, no participant receives genetic counseling in advance of genomic testing. And let me just note why that might be important. I teach students all the time about getting DNA testing. Many of them don't understand that you then become responsible for this information. And in the context of a country that does not have guaranteed insurance or health care or life insurance or long-term care, that actually is a significant thing that all people should know. This is the now of genomic medicine, a world in which there have been some remarkable successes like the ones we heard about yesterday morning and this morning, and where most of the new therapies still are projected to materialize in the future, where drugs that do exist are very expensive and entail new risks, and in which testing is exploding beyond our capacities to meaningfully and carefully interpret care, with the emphasis on medical care and care, introducing novel uncertainties into healthcare, insurance, and the lives of patients. This now is one in which we are blessed or overwhelmed, depending on your perspective, and I hear both all the time, with petabytes of genomic data, in which the major challenge is to interpret and make good on all of this data. We sequence the human genome. Now what does it all mean, and how does it matter for knowing and caring for human beings? This question is at the heart of what I've called the postgenomic condition. And this is actually a book about the 10 years after the Human Genome Project. Once we had the data, I went around the world and looked at 5 or 6 different initiatives that tried to make that meaningful in the lives of people, including efforts like Generation Scotland, which tried to enroll 50,000 people in Scotland, looking at the personal genetic testing companies here in Silicon Valley. And my insights draw on that decade-long research. So this postgenomic condition is a future-oriented now, strongly shaped by a past in which the Human Genome Project's effort to create the tools to sequence took precedent over the effort to interpret that sequence. There was actually a moment in the history of the Human Genome Project when people, including actually Craig Venter, urged devoting resources to interpretation. However, Jim Watson and others won the day and said, sequence now, leave the interpretation to generations to come. Thus, in a very real sense, the Human Genome Project produced the significant problems of interpretation we face today. We created an infrastructure very good at producing data, but not one good at interpreting, which is what we're talking about in this meeting. Despite what many argue, we do not face these challenges of interpretation primarily because doctors and patients don't understand how to interpret genomic data. We face these problems primarily because the Human Genome Project and the bioengineering turn in the life sciences it fostered built up an infrastructure geared towards producing data, not understanding it. So the challenge today, as I hope to convince you today, moves beyond education to more fundamental matters of the production of knowledge and justice. And it is critical, I argue, that we address them. For what is at stake is not just the future of genomic medicine, but the future of medicine writ large, and indeed, in many senses, the future of society itself. So what are these problems? I will present 3. First, and we've been talking a lot about this, and it's on everyone's minds, access to data. It was apparent to anyone that while sequencing the human genome was an impressive technical feat, one could know little with sequence data that was medically relevant from one human genome, even if it was the human genome. Instead, you needed data from millions, even billions of genomes. George Church, early on, was advocating for sequencing billions. And importantly, you needed this genomic data to not just come from white people. Many, instead, sought access to DNA from those of African descent early on, right as the Human Genome Project was completing, on the theory that the human species first emerged out of Africa, and so African genomes, by virtue of being the oldest, contained the most human genetic variation. However, they faced resistance, and I did some of my fieldwork at one of the places as it was happening where they were attempting to collect that data, and I'll get to that in a minute. To understand why, we must turn from the now of genomic medicine to the past. And remember that claims about genetic differences were first used not just to deny people health care, but life itself. On July 14, 1933, Nazi Germany passed a sterilization law that established genetic health courts. While most associate these atrocities with the Nazis, it was actually to the United States that the Nazis turned for the precedents. So we do not stand alone, that says in German. The state of Michigan first proposed a sterilization law in 1897, followed soon thereafter by California. It's a map of where some of those sterilization laws were. In California, from 1909 to 1979, approximately 20,000 poor women, most of whom were non-white, underwent non-consensual sterilization. This would be just one of many examples where purported genetic differences justify proposals and policies to deny racial and ethnic minorities rights and resources in the 20th century, the right to reproduce, the right to informed consent, the right to medical care, the right to education and jobs. And as late as the 1990s, unbeknownst to applicants and employees, Lawrence Berkeley Laboratories conducted pre-employment screening for genetic traits such as sickle cell and denied people jobs on the basis of it. And of course, there is the Tuskegee syphilis experiment, a research project in which the US Public Health Service from 1932 to 1972 studied, it did not treat approximately 400 African American men from in and around Tuskegee, Alabama, who were presumed to have late-stage syphilis. And as much work that has been done to say genomics is not genetics, we've moved into a different era. What you have to understand is that these histories really matter to many people, and they're not that long ago. These histories continue to matter. They have led to widespread and ongoing resistance to genomics among many non-whites. For example, where at the turn of the millennium, the National Human Genome Research Institute funded a study to collect and study the genomes of those in Macon County, Alabama, in and around Tuskegee. Very few expressed interest, although some wanted the $25. In this region of the country where people fall ill from E. coli and hookworm infections, diseases of extreme poverty caused by lack of reliable access to even clean drinking water, and where in the recent past members of their communities have been deceived by public health researchers, genomic medicine was at very best viewed as a luxury and, more to the point, a distraction from the real problems. As I was told by a researcher, actually several people, but this is a particular quote from one person at Tuskegee who had received money from NIH not to collect the DNA of African Americans, but just to talk to them about their policy concerns, and was having difficulty enrolling them even in this, explained to me, nobody's got time to worry about genomics or even think about it. It's a bunch of, an intellectual gobbledygook. It has no relevance to my life. I've got to eat, I don't have a job, I don't have a house, my job is tenuous, I live from paycheck to paycheck. I have no assets. I've got to educate my children. I mean, Black American life is about poverty or on the edge of poverty. I really don't think that anyone cares about genetics. The story that I kept being told, the church fell down on a Saturday. What if it had happened on a Sunday? There was no hospital in this community. So these were two forces. There were, however, two forces early on that helped to counteract this early resistance to human genomics. And the first were disease groups. Genomic medicine would not be possible without the tireless and incredible work of disease advocacy groups. PXE International, Force here, many breast cancer advocacy groups. These groups, for whom genetic variants may very well matter for keeping or losing one's vision or one's breast or one's life, use the tools of social media to mobilize and encourage collecting and sharing of genomic data. Ultimately, though, the most powerful force to overcome people's resistance to opening up their mouths and veins to create genomic medicine has been the market. As Eric Topol already noted in his talk yesterday, while fish in the sea and oil in the ground may be depleting, data is deluging, and not only is it deluging, it promises to solve the world's pressing problems. If only one has enough data, today anything feels or appears possible, from solving climate change to keeping kids in school to curing cancer. And this data has become the currency of the realm, and data companies have become highly valuable. Last Forbes checked, heads of these companies were the two richest men in the world, Jeff Bezos at $131 billion, Bill Gates following quickly after him, and of course, Mark Zuckerberg, who with his wife, Priscilla Chan, ranks number 4, and they of course, have just funded the Chan-Zuckerberg BioHub. Today, data is not just what you need to create knowledge, it is what you need to make money. Data about human bodies is particularly valuable. On February 23, 2018, the company that dominates the genome sequencing sector, Illumina, was valued at $34.52 billion, which might seem a drop in the bucket compared to Apple. Still no small chicken. Currently, untold billions are being invested in the development of this data into new forms of screening and data. There are high financial stakes. During the 1990s, biotech pioneered the orphan drug approach to drug development and proved that it could be highly lucrative. So some of you may know about Alexion, which created this drug, which is used to treat atypical hemolytic uremic syndrome, a condition that affects 200,000 people. At a cost of $409,500 a year, in 2010, it was the most expensive drug in the world. Now, today it's being outdone by the new gene therapies, where the projected prices that are being bantered around are over $1 million. These economic forces are a large part of what has transformed a visit to one's doctor's office into a contractual transaction. At a routine physical checkup in 2013, I received this form from UCSF It informed me that if I wanted to receive medical care, this is not a consent form, this was terms of condition. If I wanted medical care from UCSF, I had to agree to letting UCSF share my data and tissues with researchers, nothing specified as a limit, and to accept that I have no rights to any useful commercial products that resulted. And I told the story to some colleagues and friends who urged me to write this up, and I did. And it appeared on the Sunday magazine of San Francisco Chronicle with a response from UCSF saying they were working on it, they're trying to clean up the forms, it's not really what they meant, and da-da-da. But I can tell you that I heard, because of this, from other people, said, I am in a struggle with my provider too. I don't want them sharing this data. I do have a rare condition. I don't want that information leaking out. This should be illegal. So struggles like these are further eroding trust in doctors and the medical system. People then ask, who is this system for? Me or researchers? Me or industry? While market forces and contractual agreements today powerfully are combining to produce access to tissue and data, they do so at the risk of aggregating already existing problems of trust that ultimately may override the powerful, strong promises of health and wealth. For example, we heard yesterday that there are plans underway to do clinical test trials using CRISPR to treat sickle cell. Now, after years of historically low research dollars flowing to disease that primarily affects African Americans, 1 in 13 have the trait, and 1 in 365 the disease, now the spotlight is on sickle cell. And this is because it is a disease that targets a specific cell type, and so is considered ideal for CRISPR gene therapy. However, will researchers be able to recruit enough people to sign up for trial? There are some doubts about this because of something called the Tuskegee effect. Are we sitting on top of a biomedical bubble where the system may crash because it celebrates technical prowess while averting its eyes from deepening inequalities in healthcare and pays inadequate attention to too many? And this is just a sentence out of that article I just showed you, but many scientists say they've been so busy working on the science and safety of the therapies that they haven't yet done outreach they know is urgently needed. I know that NHGRI has increasingly recognized this, and I want to acknowledge that. Okay, second challenge, data, but knowledge. This point has been made many times in the meeting already, so I won't belabor it. There is a lot of data, but what does it mean? That's the postgenomic condition that we're in, is that problem is pressing. Many have faith in machine learning will solve this, but what are the limits of this big data approach to knowledge and to understanding life? I was actually very interested to hear Eric Topol say, I don't know if he really meant it yesterday, machines can't read or understand. All right, so tell you some folks I work with disagree. All I will say is that we should be careful to not go too far down the road, which I heard many times from the computer informatics people I talked to when I was doing interviews for this book, illustrated by this quote that says, I go around to give talks in front of biologists and say, yeah, I know no biology, I'm proud of it, it makes my work better. We can no longer do this and fetishize the people who know how to write algorithms over the people who study life. Okay, finally, data, but care. Here I just want to reiterate some points I've really already made. As the line between research and medical care blurs, patients have new opportunities, but they also face new challenges, including, is research eclipsing care? This great article by Robert Parrott appeared pointing to a dynamic in the country right now. Medical research, hooray! Medical care, boo! How is genomic medicine going to work in that context? It is something I hope all of you will take up as a cause. We can't have research on one side, care on another. These two things must be connected. Remember the backdrop in which all this is happening, a moment in which the methods for creating health and wealth are merging and data is the mediator. A context in which an increasing number of people either have no health insurance or inadequate insurance with high co-pays. I conclude with just a few thoughts about what this focus on the now of genomic medicine reveals about how we might address the problems of interpretation and care moving forward. Although I seem to have lost first. Thank God. The future of genomic medicine depends on broadening our vision beyond machines and the gadgets and all their data to better understand what kinds of worlds all this data is building and the practical, concrete meaning it is having in people's lives. This will mean addressing the problem and promise of just data. And this is a play. Is this just data? Is there any knowledge here? Or is this just as in justice data? So this is a problem that's of knowledge and of justice. So I would say move from the problem of big data to the problem of just data. Knowledge. Are we building a world in which we will have just data and not knowledge? Today we're producing a tsunami of data, but much less knowledge. How do we turn this around? What kinds of collectives do we need? And here's a challenge. Look around in this room and at the speakers and ask yourself, who is not here, who needs to be here to ensure that the genomic medicine of the future cares for more and more diverse people? Okay? I want you all to think of one person. Second, and interrelated, justice. With cost of therapies reaching into the millions of dollars, or into the price mark of $1 million or more, who will access the genomic medicine of the future? If genomic medicine is not going to just help the few who are well-off, well-resourced, well-connected, live in Silicon Valley or California, we will need to address the problem of drug pricing. And I just want to put a call out to this group up in the Bay Area, Fair Access Medicines. They are attempting to address this problem that insulin, this is what they're starting with, has risen 500% in the last decade. It costs way too much. They're trying to prove it doesn't have to cost this much, not just to produce it, but to get it to the consumer. So we need to buck the paradigm of drug pricing. So as we move forward, let's not aim for big data. Let's strive for just data, data that helps us to know and care for those not just in this room, and not those who are lucky enough to be under the care of the people in this room, but those who did struggle to get access to the basic necessities of life. That is the future of genomic medicine I hope we can collectively envision. Thanks.